15, 10, 9, 8, 7.
Welcome to Doctors on Call. I'm Jenna Miller. Not counting COVID-19, cardiovascular disease is the leading cause of death in the United States for men and women, and more than 800,000 people have heart attacks. There are many types of heart disease, and each one has its own symptoms and treatment. Coronary artery disease is the most common heart problem. What are the causes, and would you recognize the symptoms? Cardiology, that's our topic today on Doctors on Call with our guest, Dr. David Batten.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from at Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Russell Regional Hospital, experts, neighbors, friends.
Dr. David Batten received his medical degree from the University of Kansas Medical School. He completed his residency at the University of Kansas Medical Center in Wichita and his fellowship at the University of Tennessee Health and Science Center and William Beaumont Hospital. Dr. Batten is board certified with the American Board of Internal Medicine, Cardiovascular Disease, Nuclear Cardiology, and Interventional Cardiology. He is a member of the American College of Cardiology, Society of Cardiovascular Angiography, and Interventions, and American College of Physicians. Dr. Batten joined the Mowry Clinic in Salina in 2010. Our phone lines are open at 800-337-4788 toll-free if you have any questions regarding heart disease and cardiology on today's show. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you again for joining us this year, Dr. Batten. We have plenty to go through while we wait for those phone calls to come through. First of all, let's talk about what new procedures might be out there at the Mowry Clinic now.
So something that we just started offering in the Salina region would be the transcatheter aortic valve replacement. It is the next most logical iteration for our region and certainly augments the cardiac service line. For those that have aortic valve disease, that need to have aortic valve replacement. Traditionally, that procedure, that surgery would be done through an incision through the breastplate or the sternum. And over the last decade, that has largely been supplanted by placing it through the groin or other alternative access points. But minimally invasive, the valve is actually mounted on a catheter and can be placed in the aortic position and deployed. And basically over the last decade or so, as the larger centers have conducted trials, they have moved through different populations: extreme risk, high risk, moderate risk, and low risk. And once they demonstrated that basically any patient with this disease could do well with that procedure, it made sense to start to move that out into the market. And fortunately, that is a technology that Salina, Kansas has, Salina Regional Hospital, and of course myself at Mowry.
Does this procedure tend to be easier on the patient, or explain that?
Sure. Yeah, the procedure being less invasive now, we can do that through the groin or the femoral artery, as opposed to a large incision in the sternum. So you're basically taking an operation that would have a hospital stay anywhere from 7 to 10 days and moving that to a hospital stay of a day or two. And up and out of bed within, just a few hours after the procedure, as the groin site is generally the only entry point for the the materials or the catheters to go through.
Excellent, very exciting. What are some of the different types of heart disease?
Again, so heart disease really is a general term that refers to, the diseases of the heart, and that would be, functional, whether it's blood flow to the heart or the coronary arteries, or blood flow, away from the heart, the other larger vascular beds. Coronary artery disease obviously is one of the leading causes of deaths in men and women over the age of 50. Functionally or structurally, heart failure or weakening of the heart muscle, and then of course valvular disease, aortic and mitral being the most common in the therapies associated with that.
Can stress increase the risk of heart disease?
Yeah, sure. Stress has a lot of physiological impact on the entire body as well as the heart, and it can play a lot of deleterious roles and is certainly influential, and it's really important to not only recognize that we have stress, and of course we all have stress, but we have to manage it, and figuring out how to manage it is really what's important, to try to reduce that as a factor for heart disease.
Sure. We are going to go to the phone lines now. We've got Aaron on the line from Salina. Hi, Aaron. Go ahead with your question for Dr. Batten tonight.
Hi, my grandmother had a heart attack a little over a year ago. She was 88, in great health. That did slow her down quite a bit, but since then she has seemed to fully recover. I mean, she's bounced back. My question is a little bit twofold. I'm wondering, firstly, if she will have permanent damage, or if that ever fully recovers her heart. And then also, if once you've had a heart attack, is that likely to happen again?
Yeah. So to the first part of your question, will that heart muscle recover? And a lot of times it does. It recovers. Oftentimes, what we can at least see fully, and there's going to be portions of it that don't. But with early recognition and early treatment, we certainly can markedly improve upon what that recovery is. Now, how do you assess that? And that would be done with her doctor or cardiologist, and with an echocardiogram would be generally I think most accepted way to measure her heart muscle function to see if that area of the heart has fully recovered. The second part of that question was, will it happen again? And by and large, if you identify the risk factors that contribute to heart attacks and you aggressively treat those, the answer is no, it won't. And that's really gratifying, actually. Risk factors being smoking and cholesterol and blood pressure, diabetes, things like that. So you take your aspirin and your statin and your blood pressure lowering stuff, and you'll do real well for a long time, and she'll be dancing in her 90s.
Hey, great. Now, Erin had mentioned that I think her grandmother was 88, she said.
Mm-hmm.
So you often think of older people are the ones who have the heart attacks, but can anyone at any age have one?
Yeah. The short answer is yes. So it tends to be kind of a white male in their 50s, smoker, etc. That's kind of the people that you would anticipate that first initial event. They tend to be the ones that don't really go to the doctor all that much or recognize certain risk factors or blood pressure or smoking or whatever. But yeah, it can definitely happen at any age. I've seen it in people in their 20s, and that's not at all common. Don't freak out. And of course, as we mature and rotate around the sun, it's gonna likely happen as well. So
let's talk about those symptoms. What a person needs to be on alert for.
Mm-hmm. So the scary or the unstable one would be the abrupt onset of chest discomfort, chest pain, chest pressure, some sort of weird sensation between here and here. A lot of people don't perceive it as pain, so it's, don't really try to ask if they're having pain, and that's why I refer to it as some sort of, I don't know, weird or unsettling feeling that they have in that area. But pressure, weight light, tightness, squeezing, ache, these have all been used to describe it. Lasts for 15, 20 minutes, not going away, maybe a little bit sweaty or upset to your stomach. That symptom, that abrupt onset, etc. That needs to be dealt with right now. That can't be, don't call your doctor, don't call your sister or whoever. Call 911 or go to your local emergency room. Others are more insidious in nature, kind of slowly occurs over a long period of time, where you may start to have exertional type problems, exertional chest discomfort, chest tightness, or shortness of breath. And that happens over a period of weeks or months even. And that's, a different pathology where the blood vessel is just narrowing over a slow period of time. And that's a more stable process that can be managed for a longer period of time with medicines.
And when we were talking about stress earlier, I know, especially this past year, a lot of people have had a lot of stress, maybe a lot of anxiety. How do you know the difference between maybe just an anxiety attack and an actual heart attack?
Yeah, I mean, a lot of times you don't. I mean, you have to go get it checked out. Everybody manifests a little bit different in that regard, and if you don't want to bet your life on it at the end of the day. So you go and check it out, and if it was a stress reaction, then you can identify that and work on figuring out ways to help mitigate that. But the last thing you want to do is for it not to be a stress type reaction or an anxiety attack and end up losing a large portion of your heart muscle or even dying.
And you had mentioned aspirin earlier. Who would be a good candidate to maybe get on that regimen of an aspirin a day?
Yeah, it's a moving target. We talk about this every year, and it changes crazy. So for primary prevention, it's not generally recommended at this point. Secondary prevention, I'm using these terms, but anyway, if you've had a heart attack, it's definitely recommended. If you've been identified as somebody with coronary artery disease or other vascular disease, had a stroke or had stents in your legs or whatever, you need to be on an aspirin. And then for those of you that haven't had a heart attack, you just need to speak with your physician. That seems to be changing with the wind.
Sure. Have you seen any heart damage in patients caused by COVID-19 infections?
Not specifically. I haven't personally. The case reports and whatnot have certainly surfaced, and and I've definitely anecdotally seen patients with COVID having heart attacks, but I think this is something that we're going to continue to learn about years and years on down the road, and I'm cautious to say anything that I'm hearing now, because a lot of what we heard earlier wasn't necessarily true, and it's just not super responsible to kind of propagate myth, and we just don't know more than we know, honestly, with COVID. But
absolutely, it's ever changing in itself too. So, okay, we're going to go back to the phone lines. We've got Carol on the line from Oxford. Hi, Carol. Go ahead with your question for our guest tonight.
All right, I'm 76 years old, and I have been on Eliquis now for 14 years. Do you foresee a new replacement for Eliquis, as it's getting to be so expensive?
Yeah, I would hope that it starts to get cheaper for you. Eventually, it'll lose its patent. The anticoagulant space right now, I haven't come across anything new in that regard. The non-vitamin K dependent oral anticoagulants that you're describing, Eliquis, Xarelto, Pradaxa, there's really nothing that I'm aware of on the horizon to try to supplant them. Those are doing a remarkable job as far as safety and efficacy in supplanting Coumadin or warfarin. And depending on why you take the Eliquis, if it's for non-valvular atrial fibrillation, for example, there are options that you could pursue, such as left atrial appendage occlusion with the Watchman to come off the Eliquis. Now, if you're taking it for other reasons, which obviously I don't know your history, then perhaps you have to stay on it. But if it's specifically for atrial fibrillation, you have a mechanical option.
Talk about what congestive heart failure is. We hear that term a lot.
I think the term that people are most familiar with would be a weakening of the heart muscle or a loss of function. And when that happens, the heart muscle has to dilate to try to maintain its stroke volume and forward flow or cardiac output. And that's usually due to heart attacks or blockages in the blood flow, but it's also due to reasons that we don't greatly understand, or it's not due to a lack of blood flow, either inherited or environmental, or again idiopathic, meaning we just don't know. There's a lot of great therapies out there for heart failure these days, a lot of great drugs. That is an evolving space all the time. Just when I think that we can't make it any better, someone comes out with something else. So it's become a disease management process that has a lot of great options.
And who might be a good candidate for a pacemaker?
So people that are good candidates for pacemaker are those, first of all, they need it, right? And so they're passing out, or they have a rhythm disturbance with the wiring in the heart that is disrupted. So the top chambers and the bottom chambers perhaps aren't communicating very well, or the top chamber just, the pacemaker up there, the intrinsic one, just wants to stop working for 8 seconds or so. And those symptoms going to kind of manifest again by passing out, or periodic feeling like you're lightheaded or going to go down. Some people just get profoundly fatigued and can't do anything, and then they go to the doctor and get an EKG and say, oh, you got a problem that needs a pacemaker. And we obviously implant those devices in people that need them.
Have the devices improved over the years?
Yeah, I mean they get smaller, and they get easier to use with different technologies. They're MRI compliant and compatible. The pacemakers are a lot of them are wireless and can be implanted through just a small incision in the leg vein. So yeah, that's a technology that keeps evolving as well, and it's just as exciting as anything else in cardiology. And when appropriate, that's what's done.
You were talking earlier on the show about the new stuff happening at the Mowry Clinic or in Salina. What are some of the other different types of heart surgeries?
I think the most common obviously would be the cardiac cath, where we're taking pictures of the heart arteries and performing stents to open up narrowings in the heart arteries when appropriate. Left atrial appendage occlusion with the Watchman, which is what I was alluding to earlier, is we've been doing that for the last 3 years, which is a mechanical device that goes in the left atrial appendage that allows appropriately selected patients to come off of anticoagulation, the Coumadins, the Eliquises, the Xareltos, Pradaxas, etc. And that's been a great thing. Obviously we're very excited about the transcatheter aortic valve replacement insulin and starting to do that, and device technology continues to turn over, and I think we live in a really, it's scary but exciting time, and cardiology has always been an innovative field, and the therapies that are being delivered at the larger centers right now are focused on the mitral valve, and they're replacing mitral valves and doing repairs on mitral valves via tiny incisions in the groin now, and that's huge and very exciting.
And what causes heart valve disease?
Yeah, so in the aortic position, we don't know. I mean, someone that figures that out is, they're going to be super wealthy at some point if they can figure out why healthy skin or endothelium that should be opening and closing starts to turn to bone. And that's essentially what's happening. It gets calcified and rigid, and stops opening and closing like it should. And aortic valve disease, that's the leading cause. It's degenerative valve disease. The mitral position, a little bit different. It can be due to blood flow. It can be due to being born with a little extra tissue, which is a myxomatous mitral valve, and that tends to get a little bit beat up over time. The strings that tether the valve together can break, and that can cause the mitral valve to leak too much. If the heart begins to fail and dilate, then that affects the mitral apparatus, and you get what's called functional mitral regurgitation. So instead of having this nice coaptation, they stretch and they don't actually coapt very well, and so the blood flow comes back into the left atrium. Yeah.
Okay, and how do you determine when a patient requires a stent or a bypass?
We look at the location of the narrowings. We look at the age of the patient and all the other comorbidities or health problems that they possess. We look at the lesion length and what it's made up of. Is there a lot of calcium? And then we kind of apply an algorithm or a scoring system, and based on that we can determine if they're going to do better with bypass or with stenting. And in general, if somebody has a narrowing in what is called the left main artery, which supplies 2/3 of the blood flow to the myocardium or the heart muscle, they're going to be better suited for bypass. If there's major blockages in multiple locations and all the heart arteries are involved, if they're diabetic, for example, they're largely going to do better from bypass. It just gives them more freedom from symptoms. It gives them more freedom from repeat procedures, and it's the right thing to do.
And have those procedures improved as far as easier now than they once were?
My counterparts may disagree, but I largely no.
Mm-hmm.
Bypass is still bypass.
Mm-hmm.
It's still a major operation, largely through a median sternotomy or an incision down the breastplate, taking veins from your legs and usually an artery from the chest wall. And that hasn't changed a ton.
Sure. Now, how important is good diet and exercise when preventing heart disease or a heart attack?
It's important, to the extent to which it's important, I don't know the answer to that. It's super hard to prove, but there's no question that it's important. When you take the evidence, it's hard to demonstrate large changes, right? The most important thing when I'm addressing this with patients is, stop smoking. If you can't stop smoking, we're not going to talk about your diet, because you're 50% less likely to have a heart attack if you quit smoking. If you alter your diet, you're into that 2 to 3% changes. So those are micro changes. Identifying other risk factors, high blood pressure, cholesterol, etc. So after smoking, take your medications. So if you quit smoking, you take your medications. Now you're adding on another 20 to 30% reduction of a heart attack because you're able to take your medications. Then you can kind of really get into the weeds, diet and exercise, which is all critically important, but harder to discern those differences. And it's harder to be, I guess, compliant with diet. It's really hard to have a good diet. I think it takes a lot of focus and a lot of energy and a will to want to do it. And it really can't be a diet in terms of I'm going to go on a diet. It really has to be viewed as I'm going to change the way I'm living. I'm going to make a commitment to eat healthier, eat differently. And it's really learning about calories and counting calories and what is a calorie and getting away from, I like red meat as much as the next guy, but probably can't eat it every night, right? So less red meat, more white meat, more whole grains, less refined grains, more fruits and vegetables, legumes, nuts, etc. And if you could become a vegan, that's the best, but that's not, I can't do that. I'm not going to do that. And I can't, honestly or, speak to that.
Sure. We don't want people turning off their TVs right now.
No, yeah.
Well, thank you, Dr. Batten from Salina, for being our guest on Doctors on Call. We'll be discussing orthopedics next week. You can email us questions at doctors@shptv.org. Thank you for joining us. For Doctors on Call, I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from at Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Russell Regional Hospital. Experts, neighbors, friends.